Thank you, sir. The next topic is recent developments in management of ICH by Dr. Neha Dangayach, ma'am. I would like to invite for chairing the session Dr. Dilip Maheshwari, sir, and Dr. Sushil Tapade, sir. I would request Dr. Yashpal Rathod, sir, please chair the session.
Yeah. Good morning, Dr. Neha, and thanks for joining from New York. Dr. Neha Dangayach is a consultant neurologist and director neurointervention at Mount Sinai Hospital, New York. She'll be talking about recent developments in intracerebral hemorrhage. Now I hand over to Dr. Sushil Tapadia and Dr. Yashpal Rathod for further proceeding. Thank you.
Good morning, Dr. Neha. And after listening since morning about the stroke, ischemic stroke, and surgical management of ischemic stroke, as well as the hemorrhagic stroke by Dr. Daljit, and so many other topics we have discussed. Now, what recent is going on in the management of intracranial hematoma? So, you are most welcome, Dr. Dangayach.
My name is Neha Dangayach. I'm a neurointensivist at the Icahn School of Medicine at Mount Sinai in New York, New York. I'm the Assistant Director for Neuroemergencies Management and Transfers, and it's my honor and privilege to present to you on one of my favorite topics, ICH. I did serve as a peer reviewer for the American Heart Association ICH guidelines, which I'm going to reference quite heavily in my presentation today. So diving right in, for hemorrhagic stroke, when we think about SAH and ICH, about 15 to 20% of all strokes are going to be hemorrhagic strokes. And just like for all medical emergencies, ABC is always going to come first. Blood pressure control, reversal of coagulopathy, what diagnostic imaging do you need, neurosurgical consultation. These are very similar between what we do for SAH and ICH. And for aneurysmal subarachnoid hemorrhage, patients tend to be younger. For ICH, when we talk about primary or spontaneous ICH, these patients tend to be middle-aged or older. And a couple of things to keep in mind about blood pressure. For aneurysmal subarachnoid hemorrhage, prior to their aneurysm being secured, we are currently following this blood pressure goal. We're seeing SPP less than 140. Based on the latest AHA ICH guidelines, we are changing our practice now for an SPP goal of 130 to 150 for ICH patients. Going back to the similarities between the two, glycemic control, fever prevention, DVT prophylaxis, anti-seizure medication prophylaxis and treatment, preventing, treating different medical complications, multidisciplinary team management, instituting early, but not ultra early, not within the first 24 hours, but early rehab after 24 hours, leveraging shared decision-making, preventing therapeutic nihilism, and screening for multi-domain impairments is common to both SAH and ICH patients. In terms of the mechanism of injury, in the first 6 hours, we're really looking at the effects of that primary neurological injury. That hematoma and that expansion of the hematoma is going to happen. Early expansion is seen in a majority of the patients who are going to undergo hematoma expansion in the first 6 to 12 hours or so. And we know that with this expanding hematoma, increase in ICP, hydrocephalus, and if that remains untreated, then the potential for herniation. Beyond 6 hours, it's usually the drivers for neurological injury are secondary neurological injury, cerebral edema, inflammation, toxicity from blood products. So as a general principle to keep in mind for acute ICH management, these are all the different mechanisms that are targeted. In terms of the etiology, that's what determines the ICH location. For the purposes of this talk, we're talking specifically about primary ICH or spontaneous ICH, where there's no underlying vascular malformation. For example, AVM, dural AV fistula, aneurysms. We're not going to be talking about those secondary causes of ICH. We're going to focus on primary or spontaneous ICH, which commonly occurs because of small vessel disease. 80% of these bleeds are going to be deep, about 20% are going to be lobar, and when they're deep, they're usually because of arteriolosclerosis or small vessel disease, and lobar ICHs are usually because of cerebral amyloid angiopathy. These are the common locations for small vessel disease: basal ganglia, cerebellum, pons, and thalamocapsular region. So just keeping that in mind, the American Heart Association ICH guidelines divides the guidelines into different phases of care for ICH: the emergency acute care, inpatient course, rehabilitation and recovery, as well as secondary prevention. With improvement in ICH mortality, the focus is really moving towards improving ICH survivorship and providing multidisciplinary care and screening for multi-domain problems. So here are some class 1 recommendations for where should we initiate appropriate life-sustaining therapies. This is ABC. This should happen as soon as you see the patient. Time is brain, we've got to move fast, right? Providing care in a specialized unit, leveraging a multidisciplinary team, intensivists, neurosurgeons, endovascular specialists. If a specialized unit is not available, then transferring these patients to centers that have that kind of capability. And then particularly for patients who have ICH with IVH and hydrocephalus, making sure that they have access to a neurosurgeon who can place an EVD rapidly. Not a lot of changes here with respect to the baseline history. We're all familiar with this, and the guidelines just lay this out in a nice graphic. The ICH volume is a good volume to calculate the moment you get that scan, because it's going to help determine candidacy for certain kinds of treatments. For example, minimally invasive clot evacuation. The ICH score, of course, is derived from the volume of an ellipsoid, ABC upon 2. And it's also important to get a baseline severity score. Now, that baseline severity score, there are several recommendations in the AHA ICH guideline statement that talk about obtain that baseline severity score. It can help guide management, but it should not be used in isolation of other factors or limiting life-sustaining therapies. One key thing to keep in mind is, should you get a CT angiogram? On that CT angiogram, you may pick up a spot sign. Even on that non-contrast CT head, you will pick up certain signs, for example, hematoma with irregularities at its margins, that help you identify which patients are at a higher risk of hematoma expansion. This is a class 1 recommendation to get a rapid CT or an MRI. This is important for determining your underlying diagnosis. So there are no questions about that. Now, should you do a CT angiogram or not? This is variable. It's variable because it depends upon how high your suspicion is for finding an underlying vascular malformation. So you could use a score like the secondary ICH score to risk stratify patients. And then utilizing markers both on the non-contrast CT head as well as at CT angiogram, for example, the spot sign, to identify which patients are at a higher risk of hematoma expansion. Then comes the question of monitoring patients for stability. We know that a majority of the patients who are going to suffer from hematoma expansion will have that hematoma expand in the first 6 to 12 hours. So the recommendation is to get at least your first stability scan around 6 to 12 hours from the first one. And you could repeat another scan if you see hematoma expansion on that scan. In terms of the diagnosis and assessment, of course, there's an interesting recommendation about the venogram. It just makes me wonder, it really depends upon the underlying clinical suspicion for whether somebody has sinus venous thrombosis or not. I do completely understand about getting a CT angiogram to understand whether somebody has an underlying vascular malformation or not. And for those patients in whom the clinical suspicion for having an underlying vascular malformation is high, diagnostic conventional cerebral angiogram is recommended. Diagnostic as well as potentially therapeutic. Now, shifting gears to blood pressure control, this has been a slightly controversial area: intensive versus standard treatment. Two large randomized controlled clinical trials, which predominantly guide our current understanding of blood pressure management. There have been several post hoc analyses from both these studies, as well as several other cohort studies, smaller trials that also inform our understanding. In both Interact, which was a European study, and In ATAC2, which is an American study, there was no difference in the primary outcome of improving functional outcomes. However, a key thing to keep in mind is there was a signal towards improving functional outcomes in INTERACT2, but not in ATAC2. So while both these trials did not meet their primary outcome measure, we did infer from them that to prevent hematoma expansion, perhaps intensive blood pressure control is okay. And specifically, in follow-up studies after INTERACT2 and ATAC2 and some post-hoc analysis, this is more important. It's not just that absolute blood pressure number, but how quickly that target is achieved. So the recommendation is to reach that target within an hour. And medication titration to ensure smooth control rather than fluctuations is important. And this is a key change. If somebody has an ICH that is mild to moderate in severity, and presenting with a blood pressure of more than 150, you don't want their blood pressure to be dropped to lower than 130, because that has been associated with harm, for example, infarcts. And for patients going to that 130 to 150, in patients with mild to moderate severity, presenting with a blood pressure of 150 to 220, acutely lowering that blood pressure going to 140 is fine, but they also give you this range, 130 to 150. For us, it's important to put that in our titration instructions so that bedside nurse knows what to do with that trip. Antithrombotic related ICH. These patients